Very good morning to one and all, and thank you Dr. Soumya and Dr. Srini for having invited me to give this talk today, and thanks to the entire team at KSOS2022 for this great conference and meeting. So today my talk is on diagnosis and management of NSBVA, which stands for non-strabismic binocular vision anomalies. So I have two talks, so with the permission of the chair, can I combine both and present together, please? Thank you, sir. So basically, why are we talking about NSBVA? Because the prevalence is increasing and it is a global thing. It's not restricted to a particular geographic region or a particular age group. More so in the younger population, but you can expect a non-strabismic binocular vision anomaly in older people also. So you cannot kind of restrict yourself to testing only for children or young adults. So when I talk about NSBVA, we are talking basically about vergence and accommodative dysfunctions, right? So what are the symptoms that are commonly encountered in practice as regards to accommodative and vergence anomalies? Like people would come in complaining about blurred vision, headaches, ocular discomfort, fatigue, diplopia, motion sickness, loss of concentration while performing a near task, skipping lines while reading. The last two is more important because you have parents or teachers complaining that this child is just not following what is written on the blackboard or unable to read. While reading they skip words or entire sentences, and usually or invariably it is very sad that in our school system we kind of label those children as slow learners, or probably they have autism, or probably they have ADHD, and we just ignore them, right? So the crux of the matter is that the child probably has a non-strabismic binocular vision anomaly which has gone undetected. That's the reason why the child is unable to concentrate or skipping words and lines. Most often you find that there is a solution for it. So we as primary eye care practitioners should aggressively try to identify these anomalies which are often ignored. So when you talk about binocular vision assessment, I have, most of my slides have flow charts for ease of understanding. If you see, how do you go about assessing binocular vision? It starts with a very good case history, followed by refraction, and then you need to evaluate the sensory function, the motor evaluation, followed by vergence measurements, and then you measure the accommodative parameters. Once all these are done, then comes the most important aspect, which is case analysis and diagnosis. So once you have done that, you identify what kind of anomaly the person is having, then you counsel the patient as to what is the mode of operation with them, as to what are the kind of vision therapy that you recommend, or the solutions that you're going to be offered. What is the treatment and management protocols. And then you don't leave it like that. You need to ensure that the patient comes back to you for periodic follow-up, evaluation and management. So I will be talking about each one of them in a little bit of detail, but unfortunately given the time constraint that I have, I'm not going to be elaborating on each of the measuring techniques because it is beyond the scope of today's talk. So history. History is definitely the most important aspect because we are gathering the most information and we are having the most conversation with the patient, the child, as well as the parents if it's a young patient. So age, occupation is very important, and what are the chief complaints? Mostly you will encounter problems like intermittent blurring of vision for near or distance or both, intermittent diplopia, then asthenopia and headache. And then you could also run this questionnaire which is called the CISS Convergence Insufficiency Symptom Survey, which is freely available. When you Google it, you can download that. It is a validated questionnaire and it is very popular in binocular vision clinics to give it to your patients. Then also make a note of the number of hours of near work or computer usage. Given the current digital world, most of us are exposed to digital screens and children also. So you need to make a note of that. And if there is any previous history of any vision therapy done, and if they have undergone any kind of vision therapy, what was their compliance to that therapy. Then also talk about the general health status, because if they are under the influence of any medication, that could affect the measuring parameters too. What are the current systemic and ocular treatments, if any, and if there has been a history of ocular or head trauma. So your history should be very comprehensive and not just be a one-liner, right? Next, moving on to refraction. Refraction is the most important aspect for everybody, I would say, because most of the problems are solved if the refraction is done well. In fact, many binocular vision anomalies come up because the patient has not been corrected well. Binocular balancing has not been done, right? So it is very important that you do your objective refraction, follow it up with a subjective refraction, and ensure binocular balancing is done. So the stimulus for combination is equal for both eyes, because you might end up undercorrecting or overcorrecting in most of your subjects, and when you run the binocular vision diagnostic parameters and conduct all these tests, the values that you get would either be exaggerated, right? It won't be the right values and you will not arrive at the right diagnosis. Also, in some instances I have seen that, when the spectacles are dispensed, they are not dispensed well, where optic centering has not been done. Even a decentered optic center, lenses are what but a stack of lenses, prisms, right? So any decentration will induce unnecessary prismatic effect, and that would cause a phoria measurement also. So simply centering your spectacle lenses will solve all the problems that a subject is encountering, right? So don't underestimate the power of refraction. It is a very important aspect, and do not take it very lightly. Most of your problems will be solved if you do a very good and perfect refraction, I would say. Sensory evaluation is basically to know whether the child or the subject is able to fuse images, if there is any suppression or not. So how do you identify? By running a couple of tests like this near stereopsis charts that are available, Randall stereo test or the Titmus flight test. There's so many stereopsis measuring charts that are available, so that will give you an idea whether the person has a stereopsis or not. And sensory fusion to understand if the subject has suppression or experiencing diplopia, you do the Worth4 dot test both at near and distance. Why at both distances? Because if there is a suppression, it will tell you the size of the suppression scotoma when you variate the differences. So the boxes in each of the slide that I have given is the normative data that I have given. You need to know what the normative data is, so that you compare the results that you obtain against the normative data with the standard deviation, so you know they are going beyond the standard deviation or not. Next comes the important one, which is motor evaluation. So under this you have the ocular motility test, the cover test, the prism bar cover test, the Maddox rod test, all these to quantify the amount of deviation, the phoria measurements, and fixation disparity testing. The earlier tests like the cover test, the prism bar cover test or the Maddox rod test are measurements of phoria under dissociated conditions, right? So you measure the phoria by dissociating the eyes. When you're talking about fixation disparity, you're measuring phoria under associated conditions. Like this test may not be mandatory in all cases, but it is a useful test when you want to know whether this person will be benefited by prescription of prisms or not. Right? So if it's a symptomatic person but you're not very sure whether they will accept prisms or not, you can do the phoria measurement under associated conditions. Under fixation disparity testing, you have the mallet fixation disparity test, one of the tests. There are very available though. And then oculomotor test for saccades and pursuits is again important, especially for children where they come in with a complaint of missing or skipping lines or trying to skip words in a sentences. This testing is very, very important. Next, coming to the group of tests for vergence assessment, wherein you need to measure the AC over A ratio, the convergence amplitude and the fusional vergence, both the positive as well as the negative fusional vergence. You have tests which are direct measures of fusional vergences as well as the indirect measures. So talking about AC over A ratio, this is very important because it helps you to arrive at a correct diagnosis. So you have two methods of assessing the AC over A ratio, the heterophoria method and the gradient method. So in heterophoria method, you need to know the interpupillary distance. You add that in centimeters with to 0.4 into near foria minus the distance foria. The value that you get is the AC over A ratio, and then the gradient method is the difference between the near ocular deviation with and without added lenses. So it roughly 4:1 with plus or minus 2 is the normative data for AC over A ratio. Then comes measuring the convergence amplitude, so which is popularly known as NPC. Now NPC, most of the people that I noticed, they measure NPC using a pencil or a pen tip. That's a very wrong method because you need to have an accommodative target if you want to get the right measurement. See, all these tests will be put to good use only when the techniques that you employ are correct. You can't randomly do something just for the heck of it because the values that you get could never be right? So you need to have an accommodative target. You can use that, or you can have a pen light with a red-green filter over the patient. It is tested repeatedly. Okay, and here the normative data is given in the box there. Then comes to fusional vergence measurements. So you have two measures, direct measures and indirect measures. Direct measures are of course your smooth and step vergence testing. You're basically measuring the vergence amplitude, and vergence facility testing measures the vergence dynamics. So many a times a person can have normal vergence amplitude, but when you go in for vergence facility, when you flip, these are available as flippers, so when you flip from base in to base out, they may fail in the vergence facility testing. So that will help you to understand that the dynamics is at fault over here, and you work on improving the vergence facility. So conducting the right test is very important to arrive at the right diagnosis. And indirect measures, the following tests that I'm mentioning over here is the monocular estimation method retinoscopy, or popularly the MEM retinoscopy, NRA, PRA and binocular accommodative facility. These are basically accommodation tests, but they also indirectly measure the fusional vergences. So when I talk about fusional vergence, you can have measure it with a smooth vergence or step vergence. Smooth vergence are used with a synaptophore or a Risley prism. Step vergence we can use with a prism bar, and vergence facility is generally used with measured by a 12 prism base out and a 3 prism base flipper. So you don't have to do all the tests, do the step, do the smooth and the vergence facility. You can do just one of it. Basically you need to understand what is the vergence amplitude for distance and near, and then do the vergence facility testing. I'm just giving you the several methods by which you can measure the fusional vergence amplitude. Then coming to the accommodative assessment. Now you need to measure, just like a vergence, we measured the NPC and the fusional vergences. Likewise, for accommodative assessment, we need to measure the accommodative amplitude, the accommodative response, the relative accommodation and the accommodative facility. Talking about accommodative amplitude, all of us are aware of NPA, the most popular being the push-up method and the minus lens method. Of course, there are pros and cons to each of these methods, because push-up method, because of the proximity of bringing the target, relative magnification is a drawback. With the minus lens method, minification is a drawback. Somewhere we need to draw a line, and the normative data, you have the formula that is given in the box over there. You just have to input the patient's age, and you would get the normative data for that particular age group. Accommodative response is a very, very important aspect of accommodation testing, I would say, because this is again a very neglected testing. It is very simple to do a MEM retinoscopy, which you see this chart charts over there that's fixed over the retinoscope. It is done with room illumination. You see whether the person is accommodating for that target, and usually done at 40 centimeters. So at 40 centimeters, what is the stimulus to accommodation? 2.5 diopters. But all of us do not exert that 2.5 at 40 centimeters, right? We usually under accommodate by 0.25 to 0.5 diopters. So from this you can understand whether you have overcorrected or undercorrected the subject. If you've gone wrong in your refraction, that will show up beautifully when you are doing your MEM retinoscopy. So that will tell you whether the subject has a lag or lead of accommodation, whether they are under accommodating or over accommodating, done after the subjective refraction. Okay, so this is a monocular estimation method, so you don't even require cycloplegia to ensure whether your refraction is going correct. By simply doing an MEM retinoscopy, you will know whether the prescription that you have given is right or not. And relative accommodation, the NRA and PRA. So NRA is again an indirect measure of your positive fusional vergence, and PRA is an indirect measure of your negative fusional vergence. So I'm not going to be elaborating on how to do these tests. I'm sure most of you are aware. In case you're not, so you need to go back and read up about it, because these are very important, because unless and until you don't have the, you don't quantify what these measures, you cannot arrive at a diagnosis. Accommodative facility is done both binocularly and monocularly, usually done with an amplitude scale test. That is, the testing distance should be 45% of the amplitude of accommodation. The lens power, the flipper power, should be 30% of the amplitude of accommodation. So the flipper power is basically the lens power divided by 2. And then these accommodative flippers, you against the age, whether they fall into the normative data, how many cycles per minute they flip is what you quantify them for. So basically, talking about non-strabismic binocular vision anomalies, you conduct all the tests starting from your history, then your refraction, then the vergence, the sensory evaluation, motor evaluation, then comes the vergence measurement, then the accommodative assessments, and then now you can classify them as vergence anomalies or accommodative anomalies. So basically, when you talk about vergence anomalies, what do you commonly encounter? You can have a convergence insufficiency, divergence excess, basic exophoria, basic esophoria, convergence excess, divergence insufficiency, fusional vergence dysfunction. And accommodative anomalies that you frequently encounter are accommodative insufficiency, ill-sustained accommodation, accommodative excess, or accommodative infacility. So how do you analyze? So again, I have a flow chart for ease of understanding. So whenever you notice exophoria at distance, so you analyze the positive fusional vergence group. So when you find out that the positive fusional vergence data is low, then you evaluate the AC over A ratio and compare the distance and near phoria. So when you see that the distance phoria is more than the near phoria, that means it is a case of divergence excess. And when you find that the distance phoria is less than the near phoria, it is a case of convergence insufficiency. This is what we commonly encounter, but unfortunately, anybody who walks in for a binocular vision anomaly, most of us kind of diagnose it to be a case of convergence insufficiency without putting much of a thought to it. And if the distance and the near phoria, exophoria, is equal, then it is a case of basic exophoria. This identification is very important because your management is based on the right diagnosis. And if it is if the vergence anomaly is based on AC over A ratio, so whenever there is low AC over A ratio, it means it could be a case of convergence or divergence insufficiency. If it's a case of high AC over A ratio, it could be a case of convergence or divergence excess. If the AC over A ratio is normal, then it could be fusional vergence dysfunction or a basic ESO or basic exophoria. So sometimes you encounter that the subject is orthophoric or has very insignificant phoria both at distance and near. Then what will you analyze? You will analyze the accommodation group data. So the accommodative test that you will run the tests that kind of stimulate accommodation and you find that is low, then it could be a case of accommodative insufficiency. If the tests which show that the ability to relax accommodation is low, then it could be a case of accommodative excess. And if the subject shows that the ability to stimulate and relax accommodation is low, then it could be a case of accommodative infacility. Whether it is a Virgin's facility or an accommodative infacility, the flippers that I was talking about, the base in base out prisms, and in this case the plus or minus diopter lenses are very good in identifying, because most of the times the accommodative amplitude could be fine, but there could be a problem of infacility where they are unable to relax and stimulate accommodation. So in this case, when you find that there is an insignificant phoria and the accommodative findings are also normal, then what could be the case? So you analyze data for the fusional Virgin's dysfunction, wherein this is a condition where there is low phorias, low basin and base out values, the binocular accommodative facility, the NRA and PRA, and this could lead to diagnosis of fusional Virgin's dysfunction. Or you could analyze the oculomotor status. There could be deficiencies in both saccades and pursuits. So this could be a case of oculomotor dysfunction. So based on this, your therapy will be based. If the saccades and pursuits have a problem area, then you will train the child towards those, improving the saccadic and pursuit functioning. If all findings are normal despite doing the best of your ability, then you need to really question whether the patient's symptoms are legitimate. It could be a case of malingering also, you can't rule out that. Occasionally we do come across such patients. Next, coming to the most important aspect, if you've done all the techniques, can you restart that again please? Yeah. So case analysis and diagnosis. So now that you have the results in hand, you've done or run all the battery of tests that you could do, both sensory evaluation, motor evaluation, Virgin's testing, accommodative testing, you need to compare the results to the expected findings or the normative data. Then you group all the test results and then you identify the anomaly. So once you've identified, you will come to the next step, which is management. So a small case that I have over here is a 16-year-old who presents with difficulty in reading and focusing during near activities, does 7 to 8 hours of work near activity and digital screen usage of 2 hours a day. General health is good, no current treatment, there's no previous history of vision therapy, no history of any allergies, and is not under any current medication. These are the clinical findings. So if you see, the vision is 6.6 N6, stereopsis is good at 20 arc seconds. Rutherford dot test, fusion good for distance and near. Cover test, the child is orthophoric for distance but showing exophoria of 4 prisms base in. IPD is 60 mm. Based on that, the AC over A ratio was found to be 4:1, which is again normal. The NPC using an accommodative target showed 9 and 12 centimeters, which is the break and the recovery distances. NPA for the right, left and both eyes is mentioned over here. MEM retinoscopy showed 0.5 diopters, again which is falling under the normal category. NRA was plus 2.25 and PRA minus 3.5. The step Virgin's measurements for distance and near is given. Accommodative facility using a plus or minus 2 diopter flipper shows 4 cycles per minute for the right and left eye and 6 cycles per minute for both eyes. Virgin's facility was 7 cycles per minute. So next comes analysis. So always begin with the phoria. In this case it was exophoria, right? So you need to analyze the data in the positive fusional Virgin's group. Direct findings of base out prisms are reduced. Indirect findings, you notice that the NRA finding was reduced. MEM though is normal. Fails with plus monocular and binocular accommodative facility test proving ability to stimulate convergence is low. Reduced PFV for near more than distance. NPC is receded. Difficulty with base out prisms in Virgin's facility and difficulty with plus lenses in accommodative facility testing. So based on all this, you arrive at a diagnosis, and this happens to be a very straightforward case of convergence insufficiency, which has most prevalence in amongst all the non-strabismic binocular vision anomalies. So you may ask, if I have to conduct a binocular vision examination, do I have to run all the battery of tests, because it is pretty time consuming if you see in any practice. So there was this study which was done in India to identify the minimum test battery to screen for binocular vision anomalies. So the minimum test battery of near point of convergence with pen light and red filter, difference between distance and near foria, and monocular accommodative facility. This yields good sensitivity and specificity for diagnosis of non-strabismic binocular vision anomaly in community setup. This paper is important in a sense that most of us go out to camps, we conduct vision screening programs, but we seldom measure the binocular vision status of the child. It is just pass or fail on the vision screen, and then we end up sending the child for refraction. But by conducting or incorporating this minimum battery of tests, we can easily pick up non-strabismic binocular vision anomalies in the school-going population, in which we frequently conduct vision camps. Also, this paper, the BAN study, which was the binocular vision anomalies and normative data. Usually the normative data that I had put up in the box is the Morgan's criteria that I have put up. If you want to come close to values which are India, which is an Indian study, you can look up this paper, which is available for free access. So next comes, now we have understood the diagnosis. Hopefully by now you have an idea how to diagnose a non-strabismic binocular vision anomaly. Now how do you manage once you identify a non-strabismic binocular vision anomaly? What are the management options that are available to you? First and foremost, like I mentioned, good refraction and a good optical correction of the ametropia is the most important step. Next, you can think about anti-suppression therapy in case the subject has suppression. You can think about vision therapy, added lenses, prisms, and finally, when nothing works, then surgery is the option that is left. So what are the goals of vision therapy in Vergen's dysfunctions? I'm not going to read out everything. It is basically to enhance the fusional ranges and to enhance the accommodative convergence relationship, and to integrate the binocular function with information processing, and integrate the newly established skills with information processing. And this is just an outline of the prescribed treatment regimen in Vergen's anomalies. Like if you encounter, for instance, a case of convergence insufficiency, vision therapy and prisms are an option. Like if it's a case of basic esophoria, prisms would help in that case, followed by vision therapy. So like that, I have just enlisted the various Vergen's anomalies and what could be the prescribed treatment. Likewise, goals of vision therapy in accommodative dysfunction is to enhance the accommodative amplitudes relative to age and ability to sustain accommodation, and to enhance accommodative convergence relationship, and also to integrate accommodation with oculomotor skills. So treatment and management with respect to accommodative dysfunctions, if it's a case of accommodative insufficiency, plus lenses vision therapy would help. If it's a case of ill-sustained accommodation or accommodative infacility, again vision therapy and plus lenses would help. If there is a paralysis of accommodation, optical correction and correction of the underlying cause, what is causing that spasm of accommodation needs to be identified. Then spasm of accommodation plus lenses, vision therapy and cycloplegic agents would help. In all of these conditions, whatever course of action that you are planning for the subject, periodic follow-ups are very, very important, because unless and until you don't follow up, you will not know whether the treatment or the management protocol is working for that child or the subject, because you might need to change the course of action in midway also and go for some aggressive vision therapy at times. So only with periodic follow-ups will you be able to have a good idea. So these are the primary treatment options. See, we don't encounter all of the problems all the time. Majorly that we see in practice is the prevalence of convergence insufficiency. So the primary treatment option in this case is definitely vision therapy. The results are fabulous. And convergence excess works well with added plus lenses. In case of divergence insufficiency, prisms. Divergence excess surgery is the primary treatment option, because other vision therapy or added lenses do not help in this case. If it's a case of fusional vergence dysfunction, basic exophoria or accommodative infacility, vision therapy works. basic esophoria prisms work. Likewise, so this table kind of summarizes what should be the primary treatment option if you encounter an NSBVA. So talking about vision therapy, so you have two types. You have an in-office vision therapy as well as home vision therapy. You can have a combination of both, or if for some reason the person is unable to do therapy sessions at home, then you can call the subject in your office, in your practice, and do the vision therapy. So there are plenty of vision in-office vision therapies that you can think of: BTS3, Trinaclips, vectograms, Bernaloscope, aperture rule, Brock string. Brock string, of course, can be given to the subject and can be done at home as well. But for some reason, if they are unable to follow instructions and you think they won't be very compliant, you can ask the subject to come to your clinic and you can ask them to work on the Brock string, because Brock string is not just for convergence insufficiency. You can use it to improve the saccadic and pursuit functioning of the eye also. Synaptophore is always there, and accommodative flippers. But Synaptophore again now is an outdated instrument. Now it has become an antique piece in most of the practices with the VTS that has come and invaded the market, which has made life simpler. When I say computer-based vision therapy, they also have software which diagnoses the condition. So all these tests that you run, in case you are short of time in your practice, you have a very busy practice, I would suggest practices, big practices and hospitals to invest in good software which will help you diagnose what condition it is and also give therapy. So that's a good practice builder as well. Home vision therapy, you have the HTS, CAT cards, free space fusion cards, Brock strings, heart charts, accommodative flippers. All these can be advised. So you should know also how to administer these therapies before I give proper instructions, and again only during the follow-up visits can you find out whether the subject is compliant or not. So that is important. All said and done, you have done your job correctly, but if the subject is unable to follow the instructions that you have given or is just not performing the therapy, then you cannot expect the outcomes, right? So this is very important. So the take-home message from my talk is you need to assess group of findings, relate accommodation and divergence parameters for diagnosis. You need to train in phases and follow up for stability of parameters. Also, optimal refractive correction is the first line of management. I cannot emphasize more. Refraction is the underlining thing to start with. And learn to correlate most of the tests objectively. You need to have a table of the normative data stuck somewhere on in the wall and be able to compare the results. Always start with the relaxing procedures, Laplace lenses or basin lenses first. Then you follow up with minus or base out lenses. Try to finish the evaluation accurately and as soon as possible. I hope these are my references. In case anybody wants to look up onto these tests, the procedure, I would strongly recommend this book by Scheiman and Wick, The Clinical Management of Binocular Vision, Heterophoric, Accommodative and Eye Movement Disorders. It's kind of a Bible for all of us who are interested in NSBVA. The tests that you need to run, the way it should be administered, how do you group the findings, all that is given. It's a beautiful book. I mean, I'm a big fan of this author as well. So with this, I thank each one of you for your patient listening. Thank you so much. Kind of information as passed is the importance of assessing the non-statistic binocular vision anomaly. So the take-back message is like when we go back, we don't ignore. When you see